exam, and I don't really know how to, so I'm basically doing a bunch of UWorld questions, and then whatever one I get wrong, I'm gonna have to teach it, and whatever one that I'm like unsure of, I just kind of go over the topic. So these are my review for my questions of December 30th, 2025. So I got a question wrong on hand, foot, and mouth disease, and I kind of wanted to do a little deep dive on what it was. I have my peds rotation next. So hand, foot, and mouth disease is a sequela kind of getting a virus. Like we can have these viruses and have nothing wrong with us. We can be asymptomatic. We can have some URI symptoms, but it won't always turn into hand, foot, and mouth disease. But hand, foot, and mouth disease is a certain enterovirus, so either Coxsackie A16 or enterovirus 71 that causes hand, foot, and mouth lesions. And if you only had mouth lesions, this is called something different, and it's known as herpangina. So there is some type of infectious trigger. So most commonly, it's going to be Coxsackie A16. And then there's also enterovirus 71 that can do it. That is going to lead to macules, vesicles, and then ulcers on their hand, feet, and mouth. Typically, the mouth lesions are a little painful. There's going to be an incubation of 3 to 6 days. It's going to spread by fluids, so it's common in kids at daycares. You're going to have URI symptoms prior to getting the rash, so fever and a sore throat. And then um, only mouth lesions are typically associated with pain. This isn't going to be itchy. It's not going to be itchy on their hands. Typically painless on their hands and feet as well. Sometimes with really young kids, you can see this on their perineal region, especially those in diapers. And then again, if there's only lesions in the posterior pharynx, it's known as herpangina. And that's their posterior pharynx as opposed to like on their lips and their tongue. Another thing with herpangina is it typically onsets with a acute high fever. So they're gonna have a really high fever and then they're gonna get those after. Um, you can diagnose this with PCR testing, but this is a clinical diagnosis. And then big things of when can my kid return to school? Whenever they feel okay too and they don't have a fever, just wait like 24 hours after their fever subsides. And then if they feel up to it, go ahead because this is typically very benign. You don't want to wait until they're not shedding it because they can shed Coxsackie and enteroviruses in their stool for weeks and weeks and weeks. Biggest thing that you want to look out for with the kiddos is hydration because some of them just may present at not taking in fluids because they're going to have that sore throat or the lesions might be painful. So that's really the biggest issue here. And then with enterovirus 71, um, this one is a little bit more aggressive and it can have dissemination to the CNS. So encephalitis, meningitis, stuff like that, or they can get myocarditis. So again, herpangina is when it's just like posterior pharynx lesions, acute onset fever that's higher, and then hand, foot, and mouth disease. Here are these, and then also just understand that in African Americans they are very different in pigment, just like brown spots. Um, it looks like hyperpigmentation. Okay, so I got a question long on perineumonic effusions and empyema. It was about management of it and if you just drain it and then give them antibiotics or if you drain them and then put in a chest tube for continuous drainage. And I was like, honestly, I don't know because like pleural, yeah, I didn't know. So I also didn't really know technically what a perineumonic effusion was. And like I know of empyema, like I think of like a pus-filled lung, but I was a little bit wrong on what it actually is. So anyways, so perineumonic effusions and empyema. So, collection of frank pus or infected fluid in the pleural space, typically secondary to infection. So, this is technically a branch of a pleural effusion, and then there is infected fluid. Now, it's not always going to be pus. That's if it's complicated. So, perineumonic effusion, again, effusion due to some type of infectious trigger. Typically, there is non-sterile fluid in the pleural space. So, typically why does this happen? There is an exudative effusion. So we're going to go over the types of pleural effusions first. So review of pleural effusions, you have transitive, exudative, and then lymphatic. So transitive effusions are due to just too much fluid, so decreased drainage, so decreased oncotic pressure, like things with like nephrotic syndrome, cirrhotic patients, we're spilling out that fluid, not able to bring it back into our capillary beds, or there's a high hydrostatic pressure like in CHF. And then while Then there's exudative effusions, which is due to our leaky capillaries, capillary fluid just leaking through, not due to too low of albumin, not due because the pressure's so high. This is just because the capillaries are just spilling it out and leaking it because there's some type of leaky, permeable capillary issue going on. This can be due to inflammation, infection, malignancies, trauma, or some type of autoimmune pathology. And then lymphatic effusions is due to like lymphatic issues, so either like an obstruction or the lymphatic duct is cut. This is typically in like a surgery. So perineumonic effusions, this is exudative effusion, and the pathophys and the manifestation of this, it goes exudative effusion, some type of immune response that recognizes this exudative material in our pleural cavity. This will lead to the creation of loculations and septations of tissues. It's like a fibrotic change. And then untreated, it can lead to a fibrous shell in our pleural cavity just because it's like, what the hell? There's like this bacteria stuff in here. This is really gross. Don't like it. And what do I mean by septation? So I'm going to show you. So septations, empyema, stuff like that. Okay. It's this stuff. So you can actually see this. It's like this fibrous, get me out of here, this fibrous material, right? And it's pretty pronounced on like a chest x-ray if there's like empyema and like look at, oh, this is a gross picture. Look at this. That's what it is. Nasty, right? Like, ugh. Yeah. You can look up VAT surgeries and they just like go in there and they just go crazy with it. There's like a, oh, that is like just not good. But anyways, it's just gross. It's grossness. You don't want that, do you? That's just a bunch of adhesions. Yeah. So anyways, when there is like infection, this is like some immune response with time. And this is why you want to intervene, because if you don't intervene, this can cause like the lung just won't expand because there is like this fibrous shell keeping it compressed. So can lead to bad things. Okay? So untreated can lead to fibrous shells and scarring, preventing adequate lung expansion. Due to septations, lateral views can help with diagnoses. If the fluid collections are stuck, this is suggestive of empyema. And I meant lateral, like supine views. Views that can show you like in a cavity if it's like just stuck in this weird septation. So obviously infection is the most common cause, like pneumonia, stuff like that. But other causes are esophageal rupture, mediastinitis, trauma, or just hematogenous septicemia leading into bacteria going into that space as well because it's due to capillary drainage and stuff like that. So think about this. So there is uncomplicated versus complicated perineumonic effusions. Okay. So I mean, it's really just a pleural effusion, but when you hear of perineumonic effusion, for some reason it's very relative to pneumonia type of pathology. So uncomplicated perineumonic effusions are typically a normal exudative response due to underlying pneumonia. Like with kids, we actually really don't care about this. If they're clinically okay, but like in response to pneumonia, it's not that uncommon to have a little baby pleural effusion. And I'm sure that you've seen that many times. You know, somebody's sick, they have blunting of their causative angles, that is a perineumonic effusion secondary to pneumonia, which is expected. You know, you're having some type of inflammatory response there. It's going to be way less fluid. There's going to be no septations or lobulations. And at this point, the fluid will somewhat be sterile. But again, it's under that classification of it's like an exudative in response to pneumonia, so it's going to be perineumonic effusion. No drainage is needed for these. But if there is septations, if there is a large amount of fluid, which prompts you to do a thoracentesis, and in this thoracentesis fluid, if it has a high LDH, low glucose, and it's very acidic, it is infected, this is complicated, ultrasound is good to see septations, you are going to do chest tube drainage for these because these are at risk of developing all those like fibrotic shit that's going on. We don't want that. So if you do thoracentesis and there's evidence of bacteria in it, if there's frank pus, this is equivalent to an empyema. That's what an empyema is. It is this perineumonic effusion full of pus. These people, you can't just drain it because think of all that gunk that is in there. You want that continuously draining. And so first step is going to be a chest tube, but you can actually add like anticoagulant, like fibrinolytic fluid and medication into their pleural cavity to lessen the formation of that weird septation stuff. And then if it's severe, they're actually going to get surgery for this. So this can be a big deal. How I remembered the fluid collection of the thoracentesis stuff is I think about it of like CSF stuff. So that's like low glucose is something that you'd find, high protein. Yeah. All right. Temporal bone fracture. I had some guy present with trauma, a hemotympanum, and facial nerve palsy. And I don't know what I put, but I didn't know it was a temporal bone fracture. So here we are. So temporal bone fractures. Okay, that's our temporal bone. It really was very humbling how much I've forgotten about basic anatomy when I was reviewing this. It's very, very embarrassing. I was like, oh my God, like it's near that spot where the middle meningeal artery runs, and that's where all the sutures connect. And I was like, what is it called? It's called a pterion with a PT, pterion, just so you know. Okay, biggest thing about temporal bone fractures is going to be like a lateral blow to their skull, like, but since this kind of goes all the way down there, this can happen in polytrauma, and it doesn't have to just be like a fracture there. If there's like a fracture running through there, that means kind of all this is fractured. Okay. Okay. Um, this is considered a type of basilar skull fracture. Okay. Biggest and most important things to know is that your temporal bone has your external acoustic meatus and technically the internal one. So it's going to be associated with a lot of ear pathologies, vestibular pathology, stuff like that. And your facial nerve comes out of a foramen in your temporal bone. So facial nerve and ears is the biggest thing. So a kind of okay, kind of chill temporal bone fracture is going to present with ruptured TM, hemotympanum, and then some hearing loss, conductive at first. If it's a worse temporal bone fracture, it will actually be a sensorineural hearing loss because it's just like severed. And then this conductive hearing loss is conductive at first because of the swelling. There's worse prognosis if they have vertigo, facial nerve paralysis, or a CSF leak because that's like just more internal, just not good. Also, yeah, facial nerve paralysis is just not fun. Sometimes it could just be due to compression, stuff like that. But the biggest thing is hemotympanum, hearing loss, TM rupture. I did this twice, so that's cool. Okay, pilonidal disease. Basically how our butt crack forms. It has to do with like how our butt crack forms. And I need you to see this picture because we did not learn about embryology, but natal uh dimple. I think that's what it's called. Okay. So I feel really vulnerable right now because okay, I don't have that. But I have yeah, I have a sacral dimple, okay? And this is a high risk thing for pilonidal disease. Oops. Did not know that. But basically, it's when our body is closing our gluteal folds to create our butt crack, there is some issue. And it can create a natal dimple. Okay? No hate to natal dimple girlies and boys. I don't have something like that. Okay? Anyways, these are patients that are at risk of pilonidal disease. Other people that are at risk for pilonidal disease are people with like hidradenitis suppurativa, really bad, like sebum, occlusive disorders. There's some type of other eczema on somebody's like head that just it's very, very tragic if they have it. Whatever. Okay, so mechanical forces, disruption, and damage to our butt crack and our coccyx will lead to formation of natal cleft pores. It's basically ripping out all this hair. There's going to be debris that goes in it. It's just, friction, whatever. And then people at risk of developing this are males, people already with like sebum blocking disorders, and then natal dimple girlies and boys. Pilonidal disease is a spectrum of disorders that can be acute, there can be chronic, it can be a flare up, it can be an abscess, It can just be asymptomatic and they just have a giant ingrown hair there that's always recurring, whatever. Um, so it's important to understand that. So acute is when there is folliculitis, cellulitis, or an abscess. Um, biggest things with this is these can form sinus tracts with time, and typically a long and large piece of tissue is going to need to be excised. So you really want to do preventative care with these people because they might not understand how big of a deal it might come into. I don't know if any of you guys had like a wound care rotation or general surgery rotation, but with mine, I saw a lot of pilonidal disease and reconstructive surgery of their butt crack on a lot of kiddos, like 13-year-old kiddos, and I felt so bad for them. It's a horrible recovery, and I mean, they really need reconstructive surgery for their butt, and it's just not a fun time. And these people have chronic issues. I mean, it just looks so rough, and it just does not look pleasant, and I feel very bad for them. So, biggest thing with an acute presentation of pilonidal disease, they're gonna like complain of just pain. I mean, very logical things that you're gonna think of here. And you really want to make sure that it's treated because this can turn into a really big abscess that gen surge would probably have to drain. So basically, rule out signs of abscess. That's your biggest pearl there. And, there's different indications for treating it. Go to regular guidelines, going up to date, whatever the fuck. If you do treat it, cefazolin plus metronidazole or augmentin, um, because it's polymicrobial, you have some gut flora stuff going on there. It's not fun. When you do give them antibiotics, check them back in 2 days. If it's not getting better, change the antibiotics because you really want to eradicate this. And then also some post-surgical care, post-drainage care, whatever. You are going to tell people to always like pluck hairs out there because you don't want to cause accumulation of this stuff happening again. If abscess is present, consult gen surg, drain and monitor for fracture because these do have a tendency to recur. And then chronic is the thing of sinus tract formation, debris, cyst formation. Cysts are pretty common. They're not that symptomatic, whatever. But they might present with like persistent or recurrent drainage from their pilonidal cavity, secondary pores, abscesses with new debris. Refer them to gen surg. More common in males, and then there's the antibiotics. Some random little pearls of stuff I got. Testicular cancer, risk of cryptocortism. That's going to be your biggest risk factor. These are in younger patients that are typically healthy. It's that immobile, firm lump in their testes. And then our tumor markers are AFP and beta HCG, and they're going to get an orchiectomy or chiectomy to remove their affected testes. Uh, Never heard of this, but a shared psychotic disorder like within a household is called folie à deux. I don't know. That just had a UWORLD question on it. It was a mom and a daughter having the same paranoid thoughts. The first step is to separate them. Hypospadias, it's typically an isolated finding, but when you see this, they have a risk of different organ anomalies like Wagner syndrome or Charge syndrome, whatever. It is associated with QWERTY, which is kind of like Peyronie's, but kind of like from birth. I'm going to show you what it is. I always feel really appropriate looking these things up. So, yeah, it's, you know, similar to Peyronie's, but different pathology. But it's typically like it can be associated with it. Um, and then again, hypospadias, hypo is below. Epispadias is above. So just know that. If cryptorchism is present, you want to rule out some type of sexual abnormality. So get a karyotype. Um, with drug abuse, if you hear of perioral dermatitis, think of inhalant abuse. I mean, it makes sense to me, but I had a question on it, and I was like, "What's the most likely finding that you're gonna find on this patient?" And it was like some weird high person, and perioral oral dermatitis was the answer. And I was like, I mean, I guessed it right, but just things to know. Refresher on target levels for gestational diabetes. Fasting is under 95. 1 hour is under 140. 2 hours under 120. Do with that what you will. Um, And then pertussis, know the stages. There is uh, catarrhal, paroxysmal, and convalescent. You can give them azithromycin. And then subungual melanoma, just remember what that is. It's the melanoma on the